So these kinds of cuts really would be virtually impossible for rural areas to absorb without seeing serious consequences in terms of either people losing coverage, cutting back benefits, or cutting provider rates.
Hello, one and all, and welcome back to a new episode of The Rural Impact. I'm Michelle Rathman. And if you are a new listener to this podcast, we thank you. We are the podcast that works to connect the dots between policy and rural everything. Now, in today's episode, I'll tell you, it's one I've been eager to share with you since leaving Washington, D.C. in mid-February, just a few weeks ago, which is where many of the conversations you'll hear today were recorded. Now, I can assure you, I know the news happens so fast, but each voice you'll hear has incredibly relevant information to share. And as I mentioned to you in the last episode, I was able to spend time at the National Association of Community Health Centers Policy and Issues Forum. And then from there, I spent a few days the following week at the National Rural Health Association Policy Institute, which for me, quite frankly, is one of the most important gatherings I get to attend every year. I am proud to say that I do serve on NRHA's Policy Congress, and it is pretty fascinating for me, again, experiencing any table I can contribute in some way to be at that table. So for our new listeners, if you're wondering why I have such a heightened awareness and interest in rural health, it's because I've been working in this space for over 2 decades, and prior to that, urban health. And so if you're wondering if you should skip this episode, say, oh my gosh, we're not going to talk about healthcare again, let me see if I can make an appeal to have you stay with us for just a little while. All right, I'm going to start with some questions, and you could nod your head or shout it out loud, whatever you feel like doing. Okay, here's my questions for you. Do you receive healthcare services? And if you haven't, maybe it's time you make sure you make a wellness exam for yourself. Always put that out there. Let me ask you another one. If you need emergency medical services, whether you live in a rural area, vacation in a rural area, or just drive through a rural area, do you hope there's an ambulance to intervene and a facility nearby staffed with qualified doctors and nurses and those who are going to help potentially save your life if that is, in fact, the services that you need? My head would be nodding yes. And maybe the last question here. Do you have a family member currently enrolled in Medicaid for healthcare coverage? Could it be a child, a pregnant woman, a disabled person, or a senior? It's likely you do, and you may not even know it. For example, I'm just going to give you a statistic here. In October of 2024, there were nearly 80 million people enrolled in Medicaid and CHIP, and that's the Children's Health Insurance Programs in the 50 states and the District of Columbia. Now, at the time that I'm recording this, and it is the 3rd day of March, 2025, if you haven't noticed, America's healthcare is skating on uncomfortably thin ice. And that seems to be the consensus in the conversations that I'm having almost every day. And it might have something to do with a couple of things, such as the current budget proposal on the table is calling for colossal cuts to Medicaid as Congress looks to find $880 billion in federal savings, with Medicare, Medicaid, and Social Security, the options on the menu. Other programs and services that are bracing for impact include medical education and residency programs. You might not have any idea how, but this episode is going to help connect those dots. It also has an impact on maternal and infant health outcomes improvement initiatives, critical funding for essential public health services, and so much financial support for critical access hospitals and community health centers, already taking a beating in so many other areas. I do think, I'm going to take a breath, it's worth repeating that the quality of our collective lives indeed relies on policy. And I do bring these matters to your attention, and I thank you for listening, and frankly, to anyone who will listen, because what happens at the Department of Health and Human Services next, and on many fronts, and the decisions that Congress and the president make about the future of healthcare in the U.S. will have an enormous impact on rural serving healthcare institutions, the healthcare workforce, with rural already facing, as I said earlier, enormous staffing challenges, and decisions will impact health outcomes, life expectancy, and these are connected to rural economies and the future of their communities. So I'm not sounding the alarm bells for no reason, trust me. A reminder that these are not light subjects, but I do sincerely hope, and I do mean that even a few of the things you'll hear today enlighten. So with that said, let me introduce my first guest and an expert as she is on the matter of Medicaid, and that is Joan Alker. Joan is Executive Director and co-founder of the Center for Children and Families at Georgetown University, McCourt School of Public Policy. I was so grateful to Joan when I reached out to her. We were never in D.C. at the same time, but she was gracious enough to sit down with me before she took the main stage at the NRHA conference for a really fascinating conversation about Medicaid's role in small towns and rural communities. Here is my conversation with Joan. Hey, Joan, thank you so much for joining us. And this is, I think, one of the most important conversations I might have during this conference because everyone is talking about what is going to happen in Medicaid. A lot of critical access hospitals I work with are super concerned about Medicare Advantage, but we're going to talk about Medicaid. You're here to talk about the role that Medicaid plays in small towns in rural America. Why don't you give our listeners a taste of what that is?
Sure. So Medicaid is really an important backbone for the healthcare system in rural areas. In general, Medicaid covers about 40 to 50% of children, covers about 40 to 50% of births. And it also plays a key role at the other end of life, covering the majority of seniors in nursing homes and the primary care for long-term care, as well as lots of folks in between. So we don't hear as much about Medicaid in the public debate, and we certainly didn't hear really anything about it during the presidential campaign. But yet it is the largest source of public coverage. And its importance, as we'll talk about, is even greater for rural areas than it is for metro ones.
Yeah, I mean, I was looking at your material, and right at the end of the day, the programs, the insurance programs that are supported through the federal government are so much bigger than what people would imagine. What does it account for in terms of rural America? It's significant, right?
Absolutely. And what we found is that the rate of coverage for children in rural areas is a couple points higher. It's about 4 in 10 children in rural areas that are covered by Medicaid as compared to 38% of metro. So it's very important everywhere, but it's more important in rural areas. And I should say these numbers are actually an undercount because we use census data and that's known to be an undercount. So if you look at state-based data, administrative data, you'll find that it's closer to half of all children. But we can't break that out by rural versus urban. Medicaid plays a critical role for people with disabilities, both in terms of people who are receiving supplemental security income, also people receiving home and queue-based services, also children whose parents might have employer-based coverage. But if their child has a disability, that benefit package is not good enough. So Medicaid wraps around that private coverage. So many children who have really serious disabilities are covered by Medicaid. And that's another key point for your rural audience is that rural areas have higher rates of disability and higher rates of people with the most severe disabilities. And that's exactly where Medicaid tends to come in.
Yeah. And rather than analyze why that's so, we have to make sure that we are in the present and making sure that those individuals are not left behind. You know, I think about there's a debate, in our industry about, non-expansion, expansion states. But I think it's important for us to also identify that as your colleague, Edwin Park, talks about these draconian cuts, it doesn't care where you are on the map. It's going to impact everybody should that happen. Some of those draconian cuts might also look like significant work requirements. So could you talk just a little bit about the cuts and then some of the layers of cuts? They say death by 1,000 cuts. So let's talk a little bit about what that might look like based on what you're hearing.
Sure. So it's all happening right now. And your timing is good. And the House and Senate are moving, it seems to head on separate paths for now in terms of moving a big bill to address President Trump's priorities. Now, we're hearing out of the House that Medicaid is the top target for extremely draconian cuts. The chairman of the Budget Committee had leaked a document indicating that he wanted to cut $2.3 trillion with a T out of Medicaid. That's by far the largest amount. And this is way, way beyond work requirements. We're talking here about decimating a quarter to a third of the program. And so this would involve really destroying the current financing mechanism of the program for all states. So we're in a situation where this issue of cutting Medicaid is very much in the forefront of the dialogue. And there's a huge range. You'll see, we're going to cut $200 billion or we're going to cut $2.3 trillion, right? So a lot of numbers are being thrown around here. I think there is a growing recognition, and it's really important to understand that rural communities will be harmed even more severely by these cuts. Because, first of all, as we discussed, for children and adults, for non-elderly adults, there are higher rates of Medicaid enrollment.
Yes.
It's a more important source of insurance. And that's because rural areas have less income. They have employer coverage that's often not as available as in urban areas due to the types of jobs that you often see in rural communities. So it's not as if these folks have other options. And of course, as you know, the rural health system faces many, many challenges. Rural hospitals operating on very thin margins. So these kinds of cuts really would be virtually impossible for rural areas to absorb without seeing serious consequences in terms of either people losing coverage, cutting back benefits, or cutting provider rates, where you already have provider shortages and hospitals operating on very tight margins.
So this episode is dropping just as we are looking at, I thought it was interesting. We talked about going in different directions because I've been told, so the Senate really gets it because they have so many rural constituents and so forth, but it doesn't seem like people tell their stories, but it's not moving the dial. So as this drops, what do those of us who know how important Medicaid is, is the message that we need to be sending that maybe you think might stick versus just great story and we support you?
Yeah.
What do we need to be really pushing for at this time?
Right. At this time, it's really about hands-off Medicaid. I don't know how else to say it, but Medicaid, there really is a very active discussion, and it is not a foregone conclusion where Congress is going to end up. We just don't know. So it's all up for grabs. And interestingly, about 10 days ago, President Trump weighed in and said that he wanted to protect Medicaid and that he loved Medicaid. Now, he had not discussed Medicaid at all during the campaign. He'd said many times that he was going to protect Medicare and Social Security. But he did add Medicaid to his rhetoric about a week ago Friday. So that, I think, reflects an awareness and a concern, particularly for rural areas, that Medicaid cuts would be harmful. So this is where we are. This is really an active debate, and it is critical for folks to pipe up and speak with their members of Congress to underscore how vital Medicaid is for their communities.
Joan never disappoints. Again, that was Joan Alker, Executive Director and co-founder of the Center for Children and Families. And we'll make sure that we provide links to all of Joan's really important information about Medicaid's role in small towns and rural communities on our website. That is theruralimpact.com. We hope that you'll go there and subscribe, and then you'll get this updates and these resources right in your inbox. Okay, up next, just a few conversations from my time, just a few of them at the National Association of Community Health Centers Policy and Issues meeting. And because I never want to assume how much you might know about community health centers, here are just a few quick facts, okay? First, they are not federally owned. They are independent, nonprofit organizations, and they provide dozens of essential medical and health services to federally underserved and under-resourced communities. That's an important distinction. And as such, they qualify for funding under Section 330 of the Public Health Service Act, PHS. And because they are serving populations with many complex medical needs, very much so connected to poverty, community health centers qualify for enhanced reimbursement from Medicare and Medicaid. It's a bit complicated. So again, we'll put links on our website to help you navigate all of these ins and outs. And then another critical note of importance, I think, is that these are not free clinics. Patients pay on a sliding scale based on what they can afford. And the last point I want to make is that community health centers are governed by local boards, and 51% of those board members are patients. And I think that's important. It just really punctuates how invested they are in their community health center. So again, we'll put some links and more data and details on our resource page for this episode. And hopefully this background provides you with some context for my time with Gina Capra, Chief Education Officer at the National Association of Community Health Centers. And from there, you're going to hear a few thoughts from Wade Erickson. And Wade is the CEO of Horizon Health, an organization that for 47 years and counting provides medical, dental, and behavioral health services across rural and frontier South Dakota, which is most of South Dakota. And Wade has a perspective like no other, so stay tuned for that. But first, here is my conversation with Gina Capra.
And so I would like to start out by saying we definitely had some difficulties last week when HRSA's payment management system, known as PMS, you may have seen that on the news, when our health centers were unable to draw into their accounts the grant award for which they have all competitively been awarded. Now, I will say some of that was due to systems failure, unfortunately, at HRSA. The volume of requests coming in for that drawdown was so voluminous that I think that system got quite overwhelmed. And so health centers ran into multiple days of delay before they could draw down their funds. Ultimately, that is being resolved. We're so appreciative of HRSA's attention to ensuring that drawdown requests are being reviewed, approved, and funds are making their way to the health centers. In the interim, Michelle, payroll happens, and some health centers are operating with such a small margin that they just weren't able to make it for a couple of days. And so I think that speaks to a underlying and actually more critical issue, which is community health centers base funding is about to run out in March. And we need Congress to reauthorize and commit to the appropriation that will continue to allow health centers to be planning with some level of financial stability. And they just don't have that now. And so there's this exacerbation of the financial insecurity, not being able to plan ahead. I will say further, in the last year, we have seen health centers adjusting to the Medicaid unwinding rules.
Yes.
In all of the states. Each state is a little different as the pandemic national emergency no longer exists. And there were some reimbursement flexibilities that existed at that time. Those have gone away. And so with the churning of the Medicaid rolls, some people falling off that shouldn't have fallen off.
Yeah, many children,
unfortunately. And also those that have fallen off the rolls because that extended allowance was gone. That also has had a financial hit for our health centers who are so dependent upon getting that Medicaid reimbursement for caring for our Medicaid population, who sometimes their chronic diseases might be a little more exacerbated. And our health centers do a great job with our Medicaid patients and deserve to get paid for that. And we hope that there will continue to be support for the Medicaid program going forward. That's another really important piece to the financial strength of our health centers.
Well, this is good timing because when this episode drops, I mean, we are talking about March, and my hope, and I know hope is not a strategy. However, I do hope that there is some significant recognition that sustainability is the focus and not just eking by every single time we're up against these deadlines. So, all All right, let's talk a little bit about workforce, because we would be remiss if we didn't, identify it is not getting easier. We are seeing, primary care enrollment down and the education pipeline and so forth. What does the workforce landscape look like for community health centers right now? And what are some of the things that you guys are looking at to help alleviate some of those pressures?
Yeah, thank you so much for that question. I just want to give a shout out to all the health center workforce out there across the country. We have over 310,000 staff in health centers in all sorts of positions, from medical doctors to mid-level providers and advanced practice providers to our such critical outreach workers and front desk staff, our accountants. Everyone matters when it comes to the health center workforce. But without clinical providers, we really have far less to offer our patients. And so right now, we're very focused on ensuring continuation of the National Health Service Corps program, which has been so critical over its history, decades now, of providing dentists and physicians and nurses. We have a nurse corps program, so critical for our rural communities and underserved communities at large. The other program I would mention is the Teaching Health Center Graduate Medical Education Program, known as THC, GME.
Yes.
And this is
rolls right off the tongue.
Rolls right off the tongue after you practice a few times. This program has been so wonderful in the last, I would say it's been maybe 15 years, that we're now connecting that health centers are great practice sites for students. So for our medical residents who are looking for a way to broaden their exposure to what's possible in their careers, particularly if they're interested in primary care or family practice, to be able to go to a community health center and get the mentorship, the preceptorship that is required as part of their medical school and residency studies is just a wonderful opportunity. And we know that the data is showing that those that come through both of these programs, National Health Service Corps, THC, GME, they stay at community health centers. And that's another piece to long-term financial sustainability, is having those providers who can bill for those patient encounters.
Horizon's been around for 47 plus years. And as a business model, we plan for a short-term storm, so we had reserves. We've done this for years to make sure that we can weather, any short-term things that happen to us.
Short-term is the key.
We can't go on and do that forever. The last couple of years after the pandemic have been tough financially for a lot of health centers. Inflation, the rising costs of labor, which in our business, labor is 75% of our budget.
Yes. I try and tell people, AI, great. You'll never replace hands-on care.
Right. Yeah, that's absolutely true. And we're a people business, and that is the vast majority of our budget. And the market has changed in healthcare as far as the labor market, and trying to compete in that as a nonprofit, against the larger systems that are trying to recruit the same people we are, and it really becomes hard for us to try to, talk policy on the Hill, which is what we did yesterday.
Yes.
We had really good conversations with the South Dakota elected officials, and we're very fortunate in South Dakota. They're all in support, and they understand our challenges. They're South Dakota people as well, and they understand South Dakota's vast open spaces, and the distance between communities. So, but yeah, we're pushing on the policy side and really just telling our story of what the impact is, to our local residents.
Yeah. You know what? The last thing I want to talk to you about, and I ask every guest I can about this, because we are in D.C. and we march to the Hill and we meet with our representatives, and people say, oh, it went well. But at the end of the day, how does that manifest into long-term support? Because I think one of the things I hear so often is, man, do we have to do this every single year?
Yeah.
It is challenging to continually get our policymakers to recognize how important sustainability is. So as a CEO, what would be in your advocates toolkit a message to policymakers at the state and federal level about sustainability, not getting caught up in any of the fray that we see right now, So what would you say?
I think obviously we're spending a lot in this country and there is an effort, and I get with the new administration and we're in support of that we've got to find ways, to trim our deficit, to trim the debt. I get that. And we're in support of that. The message that we are delivering is that community health centers are not part of the problem. We're part of the solution.
That's right.
And what I mean by that is if we invest more in primary care, we can help avoid the higher cost of care, which is the specialty, the hospital stays, the ER visits.
Complex diseases from not accessing primary care.
Yeah, because you can manage a lot of those chronic conditions in primary care, which is a cost-effective approach to healthcare. Plus, it's keeping people healthier and living a better life.
My thanks again to Gina and Wade, each of them, as you heard, giving us a different perspective on the financial side of the coin where health policy shifts are concerned. But now I'm going to take you back to NRHA, and you're going to hear from the healthcare provider perspective. And, you heard Wade talk about how workforce, and too often, I think we can forget that workforce that we're talking about. They're human beings, and they are in shorter and shorter supply where rural is concerned. And, I know this firsthand while rural practicing doctors, nurses, clinical staff, everybody working in those facilities, they do have, and they've proven to us that they have tremendous capacity. They are also being expected to do much, much more with less. And the impact of policy is most certainly following them directly into the places they are caring for other human beings. So I met my first guest many years ago at the same policy meeting that we just attended. His name is Roger Wells. Now, Roger is a physician assistant practicing at Lexington Regional Health Center in Lexington, Nebraska, and he has been recognized over and over again for his outstanding contributions to his community, public health. And when you hear what he has to say about the realities of provider burnout, I really hope that it does ignite more conversations on your part in the ways that policy contributes to the state of America's rural health workforce. But before you hear from Roger, I was also elated to have Dr. Julie Wood accept this invitation to join me at the table. Also, Dr. Wood is a Senior Vice President of Science and Clinical Strategy with the American Academy of Family Physicians. Now, if you're not familiar, this is an organization where Julie shares with me 17% of its members are indeed practicing in rural. Julie is a wealth of knowledge, as you'll hear, and she and I talk a bit about the scope of practice for family physicians in rural. But first, we do scratch the surface on a burning topic that has been described to me as the iron wall standing between healthcare providers and their patients, and that is prior authorization. So here's my conversation with Dr. Julie Wood and Roger Wells. So one of the things that we hear so much about in terms of roadblocks is that there is significant challenge for physicians with things like prior authorization. Talk to us about exactly how that's impeding your profession's ability to provide the care that they desperately want to be able to do.
I think it's frustrating for patients and it's frustrating for physicians because often we are asked to get a prior authorization for something very simple and often generic or not a higher level med like it originally was anticipated, a expensive medication. So we have to stop and get on the phone and have someone who you're not even sure what educational level this person is. It's kind of a checklist perhaps, or something that you're not even sure what the rules are to approve a medication or a test. And it can be very challenging, time consuming. We have examples from my colleagues about sometimes many minutes to hours to get a medication approved or not approved. And it delays or stops the patient from getting the medication that they need.
Oh. Yeah, and that can be life or death for. I was reading a story the other day, and I don't remember what state about denial of a certain inhaler, and the young man ended up dying in the emergency room. And I thought to myself, good gracious.
I saw that story too. That was horrifying.
Yeah, what are we doing? So let's talk a little bit about. You said to me earlier that there are residents, they want to practice in rural. They want to. How do we keep that zeal, that energy up with the headwinds that we're facing? And so I applaud those who want to do it. how do we make sure that we are providing the conditions that they need to not regret their decision?
Yeah, one of the things that we're really excited about is we still see a number of our residents and students interested in family medicine, interested in rural. It's not everybody, but there's still a fair amount. So we're still really pleased to encourage that. But I think we still have to, first of all, celebrate the joy, because sometimes we get a bit hung up on all this negativity because there are concerns. And I think we need to be realistic with them, but we also need to not kind of wallow in the negativity. So I think that's really important, to give them a balanced picture of what's going on and then include them in the discussions and the potential solutions, I think is important.
Yes. And, there's that saying, if you're not at the table, you're on the menu.
Sure.
And I think that's such an important thing. And the other thing I wanted to talk to you about, because, we're having courageous conversations these days, is that we recognize that in rural communities, when I'd say OB deserts, I'm talking OB deserts. We're talking, I've worked with a hospital in one state where they had to shut down their OB services last year, and the next nearest place to go for care is 75 to 80 miles away.
And sometimes a lot more.
And sometimes a lot more, oftentimes a lot more. And then, of course, aside from distance, we do have legislation out there in state by state that is essentially criminalizing, care. So what is your organization doing? What are some of the things that you are doing, advocating for? What are some of the reliefs that, where do we go? Where do we turn? What's next?
Well, we are talking with our fellow organizations, trying to talk about how do we work together.
Okay.
That's one thing. We can't do this alone, not one type of specialty. So I think that's really important. Also, looking at what types of training we can do. And I think working together, I think there's not going to be one type of group that can do it alone. So how can we maximize what kind of clinicians can be in a community, and how can we come together?
Yeah, absolutely. And that kind of goes along the lines with, someone said to me earlier today, that we have diminished trust.
Yes, that's extremely important.
Diminished trust in health and medicine and science. And yet I also see on the other side of the coin surveys that talk about how much people trust their family doctor.
Right.
So thankfully, do you have any recommendations for us for how we fortify strength and trust in primary care, despite the political rhetoric around vaccinations that we're seeing? We have outbreaks of measles right now for a reason.
And tuberculosis.
In
my own community is an issue right now.
Oh my goodness gracious. So what do we do to change course?
For us, we continually provide our members with information and ask that they give that information and provide it in a respectful manner. And we know there's a lot of ideological differences right now.
Yes.
And so continuing to provide that information is really important, and continue to have those conversations, because we are a trusted source and we take that really seriously.
Who's taking care of you? Let's talk about those challenges.
Absolutely. I'm happy to talk about this because this is dear to my heart. You know that 90% of all physicians, and I'm a physician assistant, but 90% of all physicians report being burnt out on a regular basis, not part-time, regular. In fact, half now say that they're ready to discontinue practice or leave altogether, according to a research study in 2024. Of those 93%, 62% say that this is not sustainable and they're ready to leave. And so the survey also expressed that the daily workload is the biggest issue with administrative burden. That administrative burden says, hey, I'm working an average of 17 and a half hours a week extra in before the clinic or after the clinic or before and after hours for those individuals. It's horrible. So in the United States, right now, there are 300 to 400 physicians, that's about one a day, who commit suicide because of the unforeseeable burden.
That's astonishing number.
It's horrible.
Yeah.
And so now, by 2026, 23,000 physicians, 23,000 will either retire or leave family medicine by 2026. And it's estimated that 24% will all just leave the job within the next 2 years. So within that, we're going to experience a huge shortage if we don't start taking care of ourselves. So right now, about 5,000 new physicians are hired every year from family practice. Unfortunately, This is about 37% of all physicians who are coming out of school. But 37%, by the 5 years, 15% are remaining in family practice and family medicine. 15%. So now we'll just put that into perspective. 5% will leave and 35% will either retire or quit within the next 5 years.
You know, Roger, we talk so much about making sure that we address rural hospital closures, but my feeling is this: the hospitals are nothing but facades if we don't have those who provide clinical care within those walls, within those clinics. And let's just talk for a moment about some of the policy issues that are driving provider burnout, if you wouldn't mind going there.
Oh, I'd love to. So let's go back to about 2019 through 22, and we look at the COVID epidemic and what happened. The greatest example of a non-sustainable practice was watching the death and the watching of the people suffer without ability to change. That's the definition of burnout.
Yeah.
And so we look at that policy and what happened. We put in ventilators in all types of hospitals, but we never took care of the provider who had to now take the triple numbers of ventilators, not being able to stay, not being able to have the support staff. And so now when we look in this, we need to develop a positive attitude to decrease medical errors, which increase with the burnout. We have all kinds of deaths and falls and inappropriate medication, all because of burnout. So what do we need to do? We need to develop new teams of medical providers. So you might have a team of a pharmacist, a physician assistant, a medical assistant, a nurse practitioner, all in a team to help those people. And we can now reimburse them in an appropriate manner, not just as a provider, but as a group or a medical model at all levels, but especially in rural health, because the rural health clinic doesn't get paid for a pharmacist or a dietitian. They have to put that into the AIR, all-inclusive rate. And so we need to change the policy to look at the benefits. So I get paid to take care of a lady who is now losing her husband from Alzheimer's. I don't get paid for that. I get only paid for where she came in for her hypertension. We want to take care of the patient. We want to take care of the problem, but we want to take care of the provider by allowing them to do what they got into medicine for, and that's to help patients.
Well, you know, I don't think I told you when I introduced you to Roger how passionate he is about his work and his patients and the issues impacting all of his fellow primary healthcare providers. But as you can hear in his voice, he certainly is passionate and he cares deeply about this. And so I hope that you appreciated hearing from him. My thanks to Roger and, of course, to Julie Wood for her words of wisdom as well. Okay, moving on. I take you to one more stop, and that is back to the studio for a few brief but impactful post-DC conversations that further connect those dots to the advocacy challenges before us. So you'll recall that Joan Alker kicked us off at the top of this episode. She talked about the impact of dramatic Medicaid cuts on patients. Of course, they're very extremely significant. And my next two guests are leading the charge to bring a deeper understanding and awareness of how the proposed policy these Medicaid cuts will impact rural health clinics. And of course, rural health clinics in no way, shape, or form are spared the pain, and neither are rural hospitals. So joining me are Sarah Holman, Director of Government Affairs for the National Association of Rural Health Clinics, a very different kind of healthcare animal, if you will, serving rural America because it's not confusing enough as it is. And then we end with John Henderson. And John is the CEO of the Texas Organization of Rural and Community Hospitals. And there are many of those in the state of Texas. And here's what they have to say before I wrap up with show notes and a bit of homework for you.
So if federal funding to Medicaid is cut, states ultimately have a few different options in order to kind of try to make up within those restrictions what they can. So they can raise taxes, they can cut provider payments in the Medicaid program, or they can restrict eligibility of Medicaid beneficiaries in their states. And if we get there, it likely will look a bit different in every single state. But, NRHC's average payer mix is about 30% Medicaid. And unfortunately, unlike F2HCs, we don't get any grant funding specifically to treat the uninsured. And so if what ultimately happens throughout this is a larger uninsured population, ultimately that has significant concerns, and leading to closures of RHCs, to be frank. If the number of uninsured patients increases and or if Medicaid reimbursement, which is another, key tenet of RHC's ability to recruit providers to their facilities. If we see either of those levers pulled, we have significant concerns about the closure impacts to RHCs. Congress has recognized since it created the RHC program in 1977 that there is value in having care in rural America and that sometimes it costs more to deliver care in rural areas. And so they've done that through things like the RHC program and the Medicare and Medicaid reimbursements that RHCs have access to. That has ensured that there is care in those communities. Without that, we are risking losing access to care. And that's not something I'm okay with. That's not something that I think the 5,600 RHCs across the country are okay with. That's not something that the 38 million patients that receive care from an RHC are okay with. And if we want to support all of the Americans that live here, I think that care in our rural areas is critically important. And so saying exactly that, a lot of people are intimidated by advocacy, think that the only way you can be a true advocate is going into your members' offices and having all your one-pagers and being prepared to talk about it. Frankly, just talk about it in whatever mechanism you can. Oftentimes, members of Congress are more inclined to listen to you and constituents and the stories and information that you're able to tell than those of us that do it professionally sometimes. And I say that as a lobbyist, but just sharing those experiences and the need for access to care within your communities and truly how quickly this domino effect can result in a lack of access to care.
Medicare Advantage is a popular program, but if we go to 100% enrollment in Medicare replacement products, there is absolutely no value to having a critical access designation. And that's been protective for more than 1,000 rural hospitals across the country. We got to make sure that policymakers understand and can make that distinction.
Mm-hmm. So on one hand, it seems like there's an understanding. On the other hand, the actions, are doing something very different. These cuts that we're anticipating, and I know about you, but waiting with bated breath to see what's going to happen. So you can't dramatically cut Medicaid and at the same time believe that you're going to improve the health and well-being of rural Americans. The two just don't align, those two.
No, there is a thoughtful way to try to address some inefficiencies in any program, in any grant program, but we would hope that there'd be a thoughtful process implemented to understand the implications rather than move fast, break things, and then see who screams. Rural providers and rural communities are in no position to go through that sort of process without a lot of harm. And so we're just trying to make sure, people who are in positions of authority don't think of rural when it's too late, but actually ask questions about rural health implications of policy decisions in a proactive way.
Yes, because we're looking at so many children, millions of veterans who rely on these programs and services. So you talk about a solution in your post as community health centers or FQHCs. And I talked to a lot of folks from FQHCs who are hurting mightily right now with their funds frozen and whatnot. Since 2014, you believe that CAUSE should be able to count MA days with traditional Medicare on their cost report. It seems pretty simple. How do we make people understand how simple that really is?
Well, you can make anything health policy related as complicated as you want to make it. And
That's
sometimes
right.
we're guilty of overcomplicating things.
Yes.
So the solution that Torch is advocating for is actually an elegant, simple solution, which is just count those Medicare Advantage days as traditional Medicare on the cost report. I think the community health centers have been able to do that for about the last 10 years. And so we want to we would appreciate that same treatment. And it really is a one sentence top solution.
There's a very important date coming up in March. We need to make sure that the members of our United States Congress understand what's at stake. So many things, but what advice do you have for other advocates out there, even for those who don't really have policy or health policy on their radar screen? What is the message to our policymakers about the importance of funding our rural health safety net? And we call it that for a reason.
Yeah, so the next month is of critical importance for rural health leaders, for community members. Even if you're reluctant or uncomfortable making that call, contact your member of Congress. Let them know how important your rural hospital and clinic are to your community, and then talk about the on-the-ground impact of policy decisions being contemplated would be in your community. They have to hear that over and over again for us to have a chance in this debate.
To Sarah and John, and to all those who spent time with me in DC to discuss the heavy, heavy subject of rural health policy, thank you, thank you, thank you. And to our listeners and subscribers, please know how grateful I am for your time. I really am. And now I did promise you a bit of homework, so it's simply this. I ask that you please consider reaching out to your local, state, and federal legislators and policymakers and tell them how important access to local healthcare is to you, the impact it will have in your life or your community should Congress eliminate healthcare coverage for millions of rural Americans, including so many millions of children. And from there, one other ask for you, please stay informed. And the reason I ask you is this, because I read so many misleading and misinformed posts out there in social media about Medicaid, sometimes conflating it with other issues like border security, for example. And honestly, it can be so hard, I know this, to discern what's true and what's not true. But on this podcast, like I said from the very top, we aim to help clear things up and connect the dots and back it up with resources and references and bring you experts like you heard here today on this episode. So check our website resource page at therealimpact.com for the references I just referenced. Now, I sure would appreciate it if you would reach out to me on LinkedIn or Blue Sky. Rate this show wherever you listen. I'm spending most of my time, as I said, on LinkedIn and Blue Sky, so I'd love to hear from you there. Also, please do follow us on Facebook and send us a note from our website. Again, therealimpact.com. Hit that subscribe button for the goodies after each series. And if you do appreciate the work we're doing here to bring you this content, we do have a way for you to support us through donations. I need to mention that from time to time. Okay, one final note. Next week, we have a few more conversations from DC to bring to you. And I commit to you, we're moving in a little bit new territory, talking about innovation of rural health delivery, collaboration focused on creating thriving rural communities. You see how my face lights up if you're watching us on YouTube when I say the word thriving rural communities through the support of philanthropy. And we're going to talk with an expert on the impact of policy and health research. There is no corner policy does not reach where rural health is concerned. A quick thanks to Sarah Staub for her great editing work and to Bria Corsaro for keeping all the plates spinning. Until you join us for a new episode on The Rural Impact, please take good care of yourself and those around you. It is important for us to make time for joy. We'll see you again soon on a new episode of The Rural Impact.